Hey everyone, so we're going to talk about ultrasound guided central and peripheral venous access. And so this is part of the overall larger series about ultrasound guided procedures and why do we use ultrasound? We use ultrasound because we can actually see the procedure in real time. We can decrease the number of attempts, we can decrease the complications and improve patient safety. So today we're talking about central and peripheral access. And IVs may not be the most exciting thing on this list of thoracentesis, paracentesis, pericardiocentesis, lumbar punctures, but this is the procedure that you are going to rely on day in and day out. And being able to do an ultrasound guided IV can really save your rear end when you have a super sick patient. And so this is a procedure that everyone should really get good at and master. Because A, not just for airway, but I think about A is for access. You need access before you can do just about anything while taking care of a patient. So why do we use ultrasound for central lines? So studies have shown, and this really just validates common sense. So we can decrease the number of attempts, we can decrease the complications, and then increase accuracy. That's huge. So the traditional approach or the blind approach assumes normal anatomy. So it's called the anatomic approach, and this assumes normal anatomy. It assumes every patient's the exact same. It also assumes patent vessels. So what if you have a child with small anatomy? Yikes. Does that affect your confidence? Does that change the risk of placing a line? So this assumes that everybody is just like that picture in Netter, which we're all not. So maybe we should use caution. Maybe this is my daughter Landon, so maybe her veins are going to be a little bit smaller and trickier than a 32-year-old healthy person. What anatomic variations do we need to consider before attempting cannulation with a really big needle? Is the vein small? Yikes. How big is the target? Does the vein overlie the artery? Does it change position relative to the artery if the patient moves their head? And is there thrombus present? So what are some of the complications of placing a central line? So the number of attempts, as you increase the number of attempts, you increase the risk of a pneumothorax, of an arterial puncture, of a nerve injury, or a hematoma. So our success is improved when we use ultrasound because we're able to find veins that are not visible. You can improve your needle insertion accuracy. You can detect anatomic variants and detect thrombus. So with ultrasound, it's like you're blind and now you can see. So we can visualize the artery in real time. We can guide the needle into the vein in real time and see needle entry. I can reduce the overall time and I can reduce my complications. This improves the patient safety, so it's a win all the way around. So what's some of the equipment that we'll need? We'll need our transducer, so we're using our linear transducer. This is your high frequency probe, so it's great for your superficial structures, your nerves, your vasculature, so this is going to be your go-to. You might see a smaller hockey stick transducer with a smaller footprint. If you have it available, you can certainly use that. And you might also see a mechanical guide on the side of your linear probe or transducer. So this fixes the needle and fixes the angle of entry for performing this procedure. We want to avoid using the curvilinear probe or the phased array probe. So what about depth? So usually about 3 to 4 centimeters is your ideal depth for any vein for central access. I want to make the target big. Remember that adjusting your frequency can affect your depth. And think about then image orientation. So what is my transducer touching? Where is my ultrasound beam going? Where is my probe marker? And is the vessel in the longitudinal or transverse plane? So here, if we're doing an ultrasound guided IJ, so we're going to do an ultrasound guided right IJ on this patient, you're standing at the head of the bed. So in procedures, we're orienting the probe marker and screen to the physician, not the patient. So this is a big change in how we normally think about ultrasound, but you're orienting the probe and the screen to yourself if you're doing the procedure and not necessarily the patient. So now I have my probe marker pointing to the patient's left as I'm standing at the head of the bed, and that corresponds with, highlighted by a star, the left side of the screen. So if I'm looking at my left IJ, so I moved from the patient's right IJ in this view here. So now we're looking at the patient's left IJ. You're standing at the head of the bed. To the left side of the screen, we have their lateral neck. To the right side of the screen is their medial neck and trachea, airway. Top of the screen is the anterior face, and the bottom of the screen is their back. So their head is really towards you, and their feet are going into the screen away from you. Now, when we rotate that probe 90 degrees with the probe marker towards the patient's head and to you, now we see the vessel in long axis. So we want to make sure that we're identifying veins and arteries, and what are some of the ultrasound clues that we look for. So our veins are going to be non-pulsatile. They're thin-walled, easily compressible unless there's a clot in there. They're distensible, and they experience, or exhibit, I should say, respiratory variation. Arteries, however, are pulsatile. They are thick-walled, not easily compressible, and not distensible. So pay attention right here to the difference between the carotid artery, as seen, it's the vessel to the left of the screen. It's pulsatile, it's thick-walled, and there's no respiratory variation. And now on the right side of the screen, we see an easily distensible IJ, or internal jugular vein, initially barely visible like right now on the screen, but with Valsalva, it distends and it becomes a really nice large target, and it's thin-walled. You might see respiratory variation, distensibility. It'd be easy to collapse, and just make sure that you have a good appreciation for where your arteries are and then where your veins are. So as we approach our procedure, we want to look for needle entry. So needle entry clues are going to be tissue and vessel wall indentation, echogenic material in the vessel lumen with reverberation artifacts. So we can see the needle tip here just going into that vessel. We might see the needle tip appear on the machine that it looks like it's in the center of the vessel before it actually is. So go very slow and always check and see if you're getting any flash. And so what are some of the approaches that we use? So you have both your long axis or sagittal approach and your transverse or short axis approach. So consider the long axis versus short axis approach. What are the benefits to each? Are there any cons to either one of these? So with the short axis approach, some of the pros are you can see the artery as well as the vein and the surrounding structures. One of the big cons is you cannot see the full length of the needle, so you have to be extremely careful to follow the needle tip all the way into the vessel. So remember that in this view right here on the left side of the screen, the IJ is right on top of the carotid artery. So you want to make sure that you have the tip of your needle in view the entire time, because you can still see, even if you were looking at the middle of the needle, it might appear just like a spot right there. So you don't want to keep going, lose the tip of the needle, and puncture through the back wall of your IJ into the carotid artery. With the long axis approach, you can see the entire length of the needle, entire length of the vessel, and make sure that it's not going through the back wall. So if I use this approach, I can really drive the angle of my needle so that I can keep it in the center of the vessel the entire time. That sounds great, right? Why aren't we all doing it like that? Our IV access. Some of the cons are it's pretty technically difficult, and the probe takes up a lot of real estate on the neck, which can make the procedure more difficult. The other con is you don't really see the surrounding structures, so you have to make sure that you're looking at a vein versus an artery. Consider maybe using a short axis and then confirming needle or wire placement in long axis, or using the short axis and then switching to long axis midway through. Now, where are we going to go for our ultrasound guided central line? So location, location, location. So what sites do we use for vascular access, and what is the ideal site? So normally I think about the internal jugular vein as the ideal site, and a femoral line is what we might say is a dirty site or more prone to infection. Of course, the clinical scenario is going to dictate the type of line that we choose to place. So for instance, do I have a septic patient who's had no trauma and who needs a central line but's not crashing? I'm going to choose the internal jugular vein as my first site. On the flip side, is a patient, were they a trauma patient? Do they have a cervical collar on? Can I not access their IJ? So with that, I might choose a subclavian line or a femoral line. And also, is the patient actively coding? So is this patient being resuscitated? Do they have is somebody doing compressions on them? So I can't really access the subclavian vessels or the neck. So in that case, I'm going to go with the femoral line. So don't forget, the subclavian line is the one usually less frequently done with ultrasound, but don't forget about this. So when we're talking about ultrasound guided internal jugular vein, let's look at our anatomy. We have the trachea to the far left of the screen. So this is going to be a patient's right IJ. We have the trachea to the left of the screen, the thyroid over on top the trachea, kind of wrapping around. And then in the middle of the screen, we have the carotid artery. And to the right of the screen, we have the IJ lying just beneath the sternocleidomastoid mastoid. So this is your IJ in short axis. This is our IJ for when we're looking at the needle tip going into the vessel lumen. So we identify the IJ and the carotid in the short axis on ultrasound. Then I'm going to direct my needle at about a 45-degree angle towards the ipsilateral nipple. And I'm going to slowly and carefully make sure that I follow that needle tip down the entire way into the internal jugular vein. I'm going to make sure that I have flash as well. And then using Selger's technique, I'm going to place a wire through the needle and confirm wire placement with ultrasound. So in our long axis approach here, I can see the needle tip going into the vessel wall. The downside of this is I don't see the artery here, but I can see the needle tip and the entire length of the needle as it goes into the vein right here, and I can make sure that I'm not going through the back wall and I'm not going into any other structure. And I just want you to now appreciate the position of the IJ compared to the carotid as the patient turns their head. So oftentimes when we go up to a patient, we're going to get ready to do an ultrasound guided internal jugular central venous catheter. We'll have the patient turn their head all the way to the left. But just be careful, because look what happens when the patient turns their head to the left. You're changing the position of the IJ in relation to the carotid artery. So it went from the right of the carotid artery now to really overlying the carotid artery. So something to think about when you're getting ready to do that central line. Our next approach is going to be the subclavian approach. So when we're looking at the subclavian approach, I have the probe marker pointed towards the patient's head. So if I'm going to do a right subclavian, I'm standing at the patient's right shoulder, and now I have the probe marker pointing to my left or towards the patient's head when I'm standing on their right side. So if we can appreciate here, we're seeing the clavicle on the left side of the screen where we have this nice gray circle. Then up underneath we have the subclavian artery and subclavian vein as noted here. So if we look carefully, we're not really seeing a good image of the clavicle off to the side, but we do have the clavicle to the left of the screen, and then we're seeing the subclavian artery and the subclavian vein here. So I can use that to help guide my needle entry into the subclavian vein. Just be careful, because right up underneath the subclavian artery, you can appreciate a little bit on this image, but a bright white line. So that's going to be your pleural line just up underneath. And then our final approach is our femoral approach. So looking for the femoral vein. So remember your navel relationship. We're going to do this in short axis. So now I'm standing down towards the patient's feet. I've got my probe marker pointing to my left, which is the patient's right here. Just remember on the patient's right leg and the left leg, you maintain the relationship of nerve as the most lateral, and then as you go medial, so nerve, artery, vein. And so that's going to change from right leg to left leg, just where the femoral artery and femoral vein are. So just something to remember. So femoral artery, femoral vein, and then we move distally. And as you move distally, you're going to see the femoral artery bifurcate into the superficial and profunda femoral artery, and you'll continue to see the common femoral vein, which should be easily compressible. And then if you move even more distally, the femoral vein is going to bifurcate. So looking right here, where are we seeing that femoral vein? So, yep, if you said right underneath that femoral artery, you're correct. So that femoral vein is hidden right underneath the femoral artery. If I'm looking at this, I might take a look at the patient's other leg and see if they have anything that might be a better target on the other side. And so what about this? Not completely compressing, so this is not a femoral vein, but a internal jugular. So we're seeing some echogenic material in the lumen of that vein. We are not able to fully compress it, so getting pretty concerned about thrombus in this one. You can use pulse wave Doppler. You can confirm with Doppler, but if I'm seeing or suspicious for thrombus, I'm going to move to another site. And so what about this one? Yep, so don't necessarily rely on color flow to help you determine artery from vein when you see pulsations in both vessels. Note that your color flow can will change color as you change the direction of the or the angle of the probe. So in this one, we're just changing the direction of the angle of the probe, and that's going to change what the color flow appears to be. So keep your eye on the artery. So keep eye on the artery. Now it's red. Our vein looks blue when you can see it. Now the artery looks blue and the vein looks red. But otherwise, that's a perfectly fine vein to cannulate. And then you can also use pulse wave Doppler to help determine vein versus artery and look at your pulse wave Doppler signal. But then ask yourself, is a central vein or central venous access, your central line, is it always necessary? Or does the patient not really need a central line? They just need IV access. So we can also look at our upper extremity veins for an ultrasound guided IV access. So some of the ones that I usually look for are going to be the cephalic vein, which runs on the more lateral side of the vein. Your deep brachial veins, there are two of them, and they flank your deep brachial artery. Be careful because those also run along with the median nerve, and your basilic vein, and then your median cubital vein. So first I want to look at the patient's, both of their arms. Really, I want to see what my best approach is going to be. And sometimes if I don't see anything that's super great on one arm, I'll look on the other. And I usually use a tegaderm to cover the probe. So, and then think about, do you want to go in the long axis versus the short axis? So pros and cons to both. So long axis can be really challenging, especially if you have small wandering veins. In the short axis, so you have to be really careful to make sure you're following your needle tip the entire way. And your needle tip may appear to be in the vessel before it's actually in the vessel. So it might look, but always make sure and confirm with flash. In the upper extremity, both veins and arteries may compress, and pulsations may persist in partially compressed arteries. And it's actually, be careful for posterior vein wall puncture because your target's pretty small. This can occur with just small movements. So you're going to want to start your needle insertion at a 45-degree or less angle, and then center in vein, and then lower the angle as you thread. If you're going for a deeper vein, you might want to look if maybe 5 millimeters or greater. Think about using some local anesthetic and just creating a skin wheel for patient comfort. So what are some of the veins that I'm looking for? So deep brachial veins, I can see those on either side of the deep brachial artery, which is in the center of the screen. So 2 deep brachial veins, 1 artery, and we're seeing the median nerve. It runs along with your deep brachial vein and deep brachial artery. So looking closely, so 2 deep brachial veins, deep brachial artery. We can see the median nerve here. It's just on top of the deep brachial artery, and it looks like a little octagonal honeycomb structure. So pretty shimmery honeycomb, that's going to be your nerve. But if you look really closely, to the far right of the screen, you'll see another vein, which is your basilic vein. When choosing your vein, you want to find one with the longest path, the straightest path, so longest, straightest, and most superficial, and usually the biggest vein as well. So an ideal depth is less than 1.5 centimeters, and so with this we're going to have to use a special long IV given the depth of these veins. So looking right here as we're compressing, so you can see the median nerve here just on top of the deep brachial artery. We're seeing compression. We saw compression of our 2 deep brachial veins and our basilic vein. So coming over here, looking at that nice big structure to the right of the screen, that's going to be our basilic vein. So this is usually the most superficial vein, and it's on the medial side of the upper arm. It travels by itself. It does not have an artery hanging out with it, but it's not tethered, so it might roll a little bit easier. The other one, it's can be a little trickier, is the cephalic vein. So this is a little more superficial on the lateral side of the upper arm, can be very difficult to find sometimes. I'll say this one's patient dependent as well. So what we want to do when doing an ultrasound guided peripheral IV is follow the needle tip into the center of the vessel. So we want to make sure we're looking for the tip in the center of the vessel, fully realizing that the tip may appear to be in the center of the vessel before it's actually in the vein. Once we're in the center of the vessel and we have flash, then we're going to flatten out the needle and thread the needle. So if we go back to our geometry, our high school geometry, and remember the equation for the hypotenuse of the triangle, we have c squared equals a squared plus b squared. So what does this tell you? Your needle, really, it has to be longer than the depth of the vessel. So another approach, a more technically difficult approach, is going to be the long axis approach. So the benefit of the long axis approach is that you can see the needle going into the vessel the entire length of the way. So this helps you ensure that you're not going through the back wall of the vessel. And if you get good, you can really just steer that needle all the way into the vessel along the length of the vessel without going through the back wall and secure your vein. So to be honest, both of these take practice, and with anything, there's a lot of muscle memory that goes into performing an ultrasound guided peripheral IV as well as an ultrasound guided central line. So practice, 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 and get used to ultrasounding with your non-dominant hand so that you can do the procedure with your dominant hand, and holding the probe appropriately, allowing yourself to rest your wrist or float the probe in some gel, and having really good control of the ultrasound probe will make any ultrasound guided procedure that much easier. So let me know if you have any questions. Feel free to email me, and until then, good luck with your ultrasound guided procedures.